Is ACL reconstruction better than a hip replacement?
Patients always ask, will I be better than what I had before? And the answer for sure is not. But does the graft tear again? It's about 5% will re-tear all across all comers.
I tell people it's like two mop-ins in an aquarium. I mean, they're floating around, and it's an aqueous environment. It's not probably very conducive to any kind of stable clot.
So we're very diligent in younger patients about graft choice, and we'll get into that, I'm sure, rehab protocols, lots of things to try to make sure we optimize those outcomes. So it's the status of the meniscus at the time of the surgery. And so patients who don't have meniscus tears and get their ACL fixed have a much better long-term prognosis than folks who have a substantial meniscus pathology.
You know, I'm quite fortunate. I get to perform what's arguably the most successful surgery in all of orthopedic surgery, maybe all of medicine. It's total hip replacement. And I don't deserve any credit for it. For that, we owe our thanks to Sir John Charnley, who invented the procedure. But it got me to thinking, is there another operation that can rival the total hip replacement? I'm going to find out. I'm going to go on a tour of the most successful orthopedic surgeries and joint replacements that are available today. And I'm going to sit down with the surgeons who do them best.
Today, in my continued quest to find a surgery more successful than hip replacement surgery, we're going to talk about ACL reconstruction. And I brought in one of my partners, Dr. John McDonald, a fellowship-trained sports medicine surgeon who did his fellowship at the famed Steadman Hawkins Clinic in Vail, Colorado. John is considered one of the leaders in our area in the field of ACL reconstruction. He's performed thousands of procedures, and today we're going to talk to him about how successful this is, what's new in technology, what's new in biologics, and how he manages ACL reconstruction. John, thanks for joining us. Today, we want to talk about ACL reconstruction. And I'm on a tour of these surgeries to see, are any of them better or more successful than a hip replacement? Is ACL reconstruction better than a hip replacement?
That's a really challenging question to answer because I don't think almost anything is as good as a hip replacement. We have the benefit in most ACL tears to deal with a patient population that is very active and motivated and wants to get back to their sport. But an ACL reconstruction is not perfect, and we've got a long way to go to make sure that every single athlete gets their knee back to where they want it to be and get back to all of their activities.
It's certainly from a success standpoint seems to be quite high. I mean, most studies would show that over 90% of people would have an ACL reconstruction return to their previous level of play. Is that still a pretty accurate number?
Yeah, if you look at all comers, regardless of age or activity level, recurrent tear rate, if you're going to define that as outcome, not pain, not function, not instability, but does the graft tear again, it's about 5% will re-tear all across all comers. However, in a younger age, say teenage population that goes back to return to sport, that number can be as high as 25% in some studies. So we're very diligent in younger patients about graft choice, and we'll get into that, I'm sure, rehab protocols, lots of things to try to make sure we optimize those outcomes.
A common misconception is people say, well, if I tore my ACL, I need to have it repaired, but rarely we're actually repairing it. It's generally a reconstruction, and we'll talk about there's some other sort of new repair options that people are looking back at, but in general, still the standard of care is to reconstruct the ligament.
That's true. So historically, and we're talking 1970s or so, there was big incision in the front of the knee, stitching the ACL back together while looking at it through a big open incision. That morphed into reconstruction through open incisions, where essentially instead of repairing and you're stitching it back together, you're taking out the old ACL, you're putting in a graft, and that graft comes from that patient or from somebody else. And when it comes from that patient, it's called an autograft, and when it comes from somebody else, it's called an allograft. And then within the autograft, there's several flavors, if you will. Most commonly these days are 3: patellar tendon, quadriceps tendon, or hamstring tendons. And those are used to put a new piece of rope, if you will, in there as a new ACL. And reconstruction is by far and away more common than repair. Recently, I should say, repair has come back in vogue again with some biologic options, using your body's healing potential to try to get the ACL to heal and tighten up again. But reconstruction is the most studied and most reliable in general if you look at all comers over the last 40 years.
And I know Lindsey Vonn has brought a lot of attention to the world of ACL surgery, and a lot of people are now questioning, well, she participated in the Olympics. It didn't turn out so well, but that probably wasn't because of her ACL. But it is true that some people can if they tear their ACL, can still function at a pretty high level.
Yeah, there's great data, mostly out of Scandinavia, that shows that some patients, particularly inline athletes or a little lower demand patients, sometimes a little older too, can manage without an ACL. So it's a lot of cross country skiers, cyclists, walkers, runners, inline activities that don't necessarily require pivoting, twisting, turning. In the United States, that patient population is a lot less common. And so in our experience in my clinic, commonly we'll have patients that will maybe want to try non-operative management, but there's a fair amount of crossover, including in some of those studies, a fair amount of crossover after 3 or 4 months of non-operative management into somebody who says, I need to have an operation for this because I have recurrent instability.
My experience has always been that, maybe 1 in 4, maybe as high as 1 in 3 could probably do okay without an ACL. But the problem is we couldn't really predict who that would be. And then you don't find out until they've done more damage to their knee. Is there any progress in predicting who might do well with non-operative management versus someone who does, other than their activity level?
Yeah, age is a big factor for sure. We know that younger athletes don't do well with non-operative management and they come back. And the big issue is if you don't fix it sooner rather than later, and I don't mean within a couple of days, but I mean within a couple of months, their risk of meniscus injury, the cushion that sits in between the two bones, is much higher. That totally changes the outcome of the operation. The number one predictor of success long term may be governed by not necessarily recurrent tear, but arthritis or pain down the road, is the status of the meniscus at the time of the surgery. And so patients who don't have meniscus tears and get their ACL fixed have a much better long-term prognosis than folks who have a substantial meniscus pathology. So sometimes we'll have a patient that will have a basketball injury, pop, swollen knee, can't get it straight for a few days. They work it out on their own and they kind of think they're fine. And then they show up 6 months later. Now they have had a new injury. They twisted, they felt a pop in their knee, and now they can't get their knee straight, and they've got a very specific meniscus tear that requires a surgery that maybe we could have avoided had we fixed their ACL or seen them earlier on in their injury course.
Yeah, I think that seems to be a common misconception people have is differentiating pain from stability. And really the ACL is about providing stability. Pain in and of itself is not really the driver for surgical reconstruction.
Yeah, that's exactly right. The ACL reconstruction surgery is not a pain relieving operation. It is an instability operation. And so a lot of patients will try, let's say you have the 55-year-old, weekend warrior who tears his or her ACL and their big sport is cycling. A very real argument can be made for that patient. Hey, let's try some non-operative management here. You're not playing soccer with the teenagers. You're not snow skiing necessarily. This is your sport is cycling, and that's how you like to stay fit. And you go to the gym. You have a very good chance of avoiding an operation on that ACL. But you shouldn't make that decision when your knee is all painful and swollen in the first 7 days afterwards. If you're going to give it a go, you give it a go and see, do you have an unstable knee in the future? And that would be the reason to go and fix that ACL.
My brother had an open ACL repair, primary repair back in the 70s, and I don't think it works very well. Can you explain why that doesn't work very well?
Yeah, the ligament itself has a couple of different bundles, if you will. So it's like two different wads of rope that come across between the femur and the tibia in a very specific angle. When the ACL tears, those pieces of rope, those strands stretch a bit and fray. And even if you can stitch them back together, they may, or even if you treat it non-operatively and you get an MRI that shows that the ligament itself is intact, those fibers often are not quite as structurally sound as they were before. And so although it may look good with stitches across it, there still may be substantial instability in the ligament itself where it's just not as tight as it used to be. And it's very challenging to reproduce that structural stability in that rope.
I tell people it's like two mop ends in an aquarium. I mean, they're floating around, and it's an aqueous environment that's not probably very conducive to any kind of stable clot formation or, so I know we'll talk about that a little bit more, but it's kind of making a comeback. So many of these things we're going to talk about are cyclical, like so many other things in medicine, that we just try something that we've done before and put a new spin on it. Sometimes they work, and sometimes we gave up stuff that worked pretty well in the past, and it's making a comeback. We'll talk about that as well. Okay, so I'm a 16-year-old female soccer player. I had a non-contact ACL injury. I come to you and I say, I want my ACL reconstructed. And I know one of the big discussions is over graft choice. What, in your mind, does that discussion look like? What do you offer them? Do you have a preferred graft choice, or do you feel it needs to be individualized to the patient?
Yeah, I think most fellowship trained sports surgeons will do multiple different graft options as part of their repertoire. So whether that's quadriceps tendon, and we take either a portion of the tendon or a piece of the kneecap with the tendon, or we take patellar tendon with pieces of bone on either side of it. That's bone, tendon, bone, or we take hamstring tendons, and then obviously allograft, which we talked about a minute ago.
From the cadaver.
From the cadaver, that's right. So I think it's really important to optimize graft for each individual patient. So this is where I think it's a challenge as a patient to try to do your own research on this, because there's a lot of nuance to that choice. What we have found over the last 15 years is hamstring grafts have fallen a little out of favor. There's multiple studies showing a little higher infection rate. Kind of hard to understand why that is. There's also studies that show that hamstrings in loosey-goosey folks, people that hyperextend their knees 10 or 15 degrees, particularly young girls, have a higher re-rupture rate with that autograft. And there's a huge cultural bias. So Europe has a very big predominance of autograft using their own tissue, mainly because of availability of cadaver graft in Europe in comparison to the United States, where it's much more readily available. So even a 45-year-old might get their own tissue in Europe used, whereas in the United States, almost always that's a cadaver graft for most surgeons and most patients.
As a 16-year-old soccer player, I'd say I'm pretty lax. My elbows hyperextend. I can bend my thumb back to my forearm.
Mm-hmm.
I didn't damage my cartilage or my meniscus at all. What would you tell me I should do?
I think that's a 1A, 1B patellar tendon or quadriceps tendon, and it depends a little bit on the surgeon preference at that stage. I would say 10 years ago it was patellar tendon every time. Nowadays, quadriceps tendons become more popular, and it has a smaller incision, a little more cosmetically acceptable, avoids oftentimes a little higher incidence of front of the knee pain or pain with kneeling on it than the patellar tendon has. Quadriceps tendon very commonly is a cuboidal piece of tissue. So in contrast to the patellar tendon, where it's more ribbon-like, the quadriceps tendon has nice cuboidal piece, three-dimensional shape to it. A lot of surgeons believe that gives us a little more collagen, a little more rope, if you will, to put into the knee as to help reconstruct the ACL. Both of them have a lot of great data that shows their re-rupture rates are very similar. There may be some emerging data as quadriceps has become much more popular in the last 5 to 10 years. We're starting to see some newer data around their outcomes, that some arthrofibrosis, that means scar tissue in the knee, can happen more commonly in quadriceps tendon than it does in patellar tendon. That might necessitate another surgery down the road to release that scar. That might be a potential negative in somebody who shows signs of a chance that they have increased risk of that. Let's say keloids on their skin, so they get extra scar on their skin, might be a sign that this person has a higher incidence of scarring into their knee. You might err on the side of patellar tendon for that patient over quadriceps tendon. So there's a lot of nuance to that. So I think for the 16-year-old female soccer player, a little bit loosey-goosey in her joints, we're having a conversation about quadriceps versus patellar tendon, and I'm probably erring on the side of quadriceps tendon these days.
And one of the advantages of patellar tendon used to always be that because it has bone, you get more reliable bone-to-bone healing, maybe quicker return to play. I don't know if that's still true, but so if you're taking a quad tendon, do you take a piece of bone off the kneecap with it, or just use the soft tissue itself?
Yeah, typically I'll use the soft tissue itself, so we don't have to violate the patella, the kneecap. But in revision situations, we'll take patellar bone with the quadriceps tendon in an effort to try to fill a tunnel that's too wide in a revision second surgery, as an example, when they've already torn their first ACL. The reason quadriceps tendon has become more popular more recently is because of some newer technology that allows us to stitch that tendon and hold it in place reliably well to heal to the bone. Your point about bone-to-bone healing is accurate. The patellar tendon graft with bone blocks in the tunnels that we drill in the femur and the tibia do integrate faster than soft tissue does, probably 6 to 8 weeks as opposed to 10 to 12 weeks. But the rehab of an ACL is not governed necessarily by graft healing anymore. It's really, we know now it's governed by strength and ability to control the knee dynamically. And so physical therapy is incredibly important, and that rehab protocol. And then the psychological readiness for return to sport is also very important.
Yeah, I've read that that's really become come to the forefront as being a very strong predictor of return to sport is the psychology of it, not so much the mechanics and the healing of the graft.
Yeah, the number one reason adults don't return to sport after an ACL reconstruction is because they don't want to get hurt again. And so they just said, I went through this process and I thought I was going to get myself back to it. And now I just don't want to get hurt again. And our job as their advisor and surgeon and a partner through this process is to give them the confidence that you've got a knee that'll allow you to go do the stuff you want to do. And so psychological readiness is a real important factor for us.
It used to be true, and I don't know if it still holds true, that once we reconstructed someone's ACL, we could tell them, well, you're actually probably more likely to tear your other ACL than the one we just reconstructed. Is that still true?
Well, again, if you go back to that number of 5% retear rate, regardless of age, the numbers show in big studies 8% retear rate of the other ACL. And so if you think about it that way, then that's true. Patients always ask, will I be better than what I had before? And the answer for sure is not. We cannot reproduce the nuance to that ligament in the way that you were born with. The way that the blood vessels supply to it, the pattern in which it spreads out over the tibia and the femur, the two bones where it attaches to, and the nerve innervation to it, we cannot reproduce in an anatomic way exactly like you were born with. And so it's a great, maybe the best way we can so far, attempt to try to reproduce that. It's not as good as what you were born with.
I think one of the more fascinating things in medicine is that, these reconstructions are with tendons, not ligaments. Tendons are tissues that attach muscle to bone. Ligaments attach bone to bone, and they provide structural stability. They're like hinges in some situations. But the interesting thing is that tissue that we implant as a tendon, it actually turns into a ligament.
Yeah, so there's this idea of ligamentization where the biology of your knee or of your of whatever part you're working on in the human body, actually those cells will alter the way that they function based on the stresses that they see in the environment that they're in. We see it in hips with hip arthroscopy and labral tears that we put in tissue as a reconstruction, sometimes in revisions. That might be a tendon from the foot and ankle that we put into a hip. And if you go back and biopsy that tissue a year later, that tissue looks like normal labral tissue, the piece of tissue that runs around the outside of the hip normally. And the same thing occurs in the knee. We can follow some of that maturity process via MRI and see sometimes if somebody wants to go back to return to sport at a faster time frame, we might MRI them and see what is their ligament, what does their new graft look like? Is it mature, or does it still have an immature appearance to it on the MRI with a bunch of inflammation still and that sort of thing? And that might help guide how strong is that graft and is it ready to see the stresses that you might experience in a sport?
And going back to medicine recycling itself, I've seen a number of patients over my career, and I'm guessing it was around the 70s or 80s when they did this, when they would use what we call an extra-articular reconstruction. They would take the IT band, which is a band of tissue down the side of your leg, and sort of pull it over and have it act as a functional ACL. And they did really pretty darn well. And I don't know why it got abandoned, but it's now kind of making a comeback. So I'm that 16-year-old girl. You just did a quad tendon ACL reconstruction on me. Are you going to add, that's what's called an LET? Are you going to add that to my surgery?
Yeah, it's funny the way that things come around again, because 20 years ago, my attending physician in my residency program taught me, hey, you can take a piece of the IT band and you can put a screw into the back of the femur and just give a little bit of extra rotational stability in a revision setting or in a patient who is loosey-goosey joints. And that largely got abandoned for a period of time. It's hard to understand quite why. Maybe because we thought our reconstruction grafts, as the evolution of where we placed that graft on the femur and on the tibia changed over the course of the 90s and 2000s. We thought, oh, maybe we don't need to add on this extra stability on the outside part of the knee. In newer data, I remember several years ago,
I think the advent of the arthroscope.
Right.
That was another tool looking for a use.
Yeah, exactly. And they said, oh, we found a new ligament, the anterolateral ligament. And of course that was, the ligament's been there all along. But everybody thought, oh my gosh, this discovery is going to alter ACL reconstruction. In reality, it's just this area, this part of the knee gets stretched when you tear your ACL. And then we have to find a way in some patients to try to tighten that up. In an LET, a lateral extra-articular tenodesis, most commonly also called a modified lemare, where a strip of the IT band is taken and tied in, has come a long way too. And there's great data now that shows that augmenting an ACL reconstruction, including in a primary, meaning their first time surgery for it, in a loosey-goosey patient or a patient going back to cutting sports at a young age, that augmenting that reduces re-rupture rate. And so that's become a more routine part of my practice, I would say, in the last 5 years. Additionally, there's some technological advances that allow us to not put a big old screw and washer back there. We can do it through a much smaller incision than was done 30 years ago, and tie it into the side of the femur. And then lastly, that strip of IT band is used commonly in pediatric ACLs still. When the growth plates of the bones are open, and by drilling tunnels in the femur and the tibia to reconstruct the ACL, you might disrupt that growth plate and alter the alignment or growth out of that bone for that younger child, usually in a 12 or 13 or 14-year-old or even younger. A strip of the IT band can be wrapped around the back of the femur and laid in on top of the tibia, and it does a great job of reconstructing the ACL and avoiding those growth plates in very young patients.
Okay, I know I don't look like a 16-year-old girl, but you haven't answered it. Are you going to add an LET to my quad tendon ACL reconstruction?
If you're truly loosey-goosey, meaning you have hyperextensible knees and a thumb to forearm test that's positive and elbows that hyperextend, and you're going to go back and play soccer or volleyball or basketball in a cutting sport, we're going to do a quadriceps tendon autograft, and we're going to do an LET.
It's also funny, I think, there's something called a Sagoon fracture, which I know you know what that is, but it's a sort of characteristic x-ray finding of this little piece of bone off the side of the tibia, the shin bone, that tends to pull off when people tear their ACL. And we always kind of wondered, what does that have to do with an ACL? It's nowhere near it, but it's actually part of that failure of that ligament. And that whole new ligament discovery story was, boy, it's surgeons that drove us crazy. It was just clickbait. And, I had friends text me, how did you not know there was a ligament in the knee over here?
Right.
Like, and they just called it something that it went. But anyway, it's an interesting story. I think it's interesting that it's come back. And like I said, people who had that in isolation, even adults, the ones I saw, and I haven't seen the data on it, they did remarkably well. And I think you bring in a really important question up for me, is that when I did my fellowship, it was, if you had open growth plates, we had to say, sorry, you need to wait till they're closed. Because when we create our classic ACLs drilling across that growth plate, it could cause it to arrest and cause growth deformities. And that was really hard. Mm-hmm. And now, can you comment on the fact that with the sort of professionalization of youth sports, that are we seeing more and more younger people tear their ACL now?
For sure. There are just so many more kids playing sports and playing one sport year round that puts them at increased risk for injury. Historically, people would play football and basketball and baseball 3 different seasons, and then they'd go to college and might play one of those sports. Nowadays, early sports specialization is a huge problem, and actually the data shows that until about age 13 or so, playing multiple sports before that dramatically decreases injury rate, burnout rate related to their sport, and increases their ability to make it to elite athlete, that's Olympic or professional status. And so we encourage all of our young patients to really not specialize early. There are a few exceptions to that. Figure skating and martial arts kind of fall into that, as well as gymnastics potentially. But for the bulk of the major team sports, early sports specialization is not encouraged. And a lot of the coaches have picked up on that, thankfully, at this stage. Youth sports industry is a multi-billion-dollar industry, and any parent watching who's paid an extra $15 or $30 to watch their kid play in a volleyball tournament that they already paid several $1,000s for them to be on a team for understands what I'm talking about. And there are a lot of hands in the pot trying to get these athletes to do things that may not always be in their best interest. So we always try to be the best advocate for our patients.
A big topic then is the difference in gender rates of ACL tears. We still see this at a markedly higher rate in females than males. Have we ever figured out why that is the case?
I think in gross number, we still have men or boys and males higher than females, just in terms of overall number, because of the difference in the number of those folks who play sports in general or put their knees at risk. If you look at a per capita, you're exactly right. And so on a percentage basis, young ladies tear their ACLs at a higher rate than young guys do. A lot of that has to do with being a little looser in their joints, having landing mechanics that are a little bit different. The wider pelvis that most women have in comparison to guys alter the way that their knee bends when they land coming down from a jump, and they often land a little more knock-kneed. Hip rotation strength is a really big key driver of that, which is why a lot of pre-season strength training programs exist that are ACL prevention protocols, most commonly the FIFA 11, but there are several others, have great data that show by strengthening some of the muscles around your hips specifically and your knees and focusing on landing mechanics that you can markedly reduce the risk of ACL injury in season. But as soon as you stop doing those exercises after the season, a lot of those old habits show back up again. So it's a lot of off-season training, and it's a lot of in-season training, not every day, but strength training, working on landing mechanics and hip strengthening to reduce that risk. And it's much more common, or much more important, I should say, in the young female athlete.
It seems like it's a very effective intervention, but the problem is the compliance. I mean, and it's almost designed to be a part of their warm-up program, right? I mean, it's not some major go visit a physical therapist in the office, take an hour out of your day kind of thing.
Yeah, we have done we've put a lot of time and effort into local high schools here in the Austin community, working to incorporate this into their summer protocols, especially for the fall sports, the football and volleyball, and some of it's cost too. I mean, having access to some of these, to a gym or to a physical therapy office or to a training room, things like that. Some of it's compliance, like you said. It's hard to get a teenager to do anything that doesn't necessarily show immediate impact into their lives. And frankly, it's hard for me to see that too. Yeah. So it takes a lot of diligence. And if you have a motivated parent or a motivated coach that can drill that into their head, it has tangible benefits.
Is there a resource people can go to if they want to learn about FIFA 11? Is it something they can download off the internet, or how do they enroll?
Yeah, I mean, if you Google it or go to ChatGPT, and they'll show you all the exercises.
I'll put a link in the description, so they can literally go down
and see the exercises.
Okay.
Yeah, we give it out to them as a handout. Oftentimes, when I see a young athlete with it comes in for a random knee sprain that doesn't necessarily need some big operation or MRI, but I know they're going back to an at-risk sport, we'll give them the handout and say, "Hey, are you doing this? And here's a little education about this." And parents are always pretty grateful about that.
Learning from our friends that take care of our furry friends, the veterinarians. The way they deal with ACL reconstructions is actually by doing what's called an osteotomy, typically. I believe they break the bone. And the reason for that is the slope of our shin bone, if it's tilted up or down, does have an influence on how stable our knee is. Is that something you routinely look at? Is an osteotomy ever part of your arsenal in the treatment of an ACL tear?
Yeah, that's a really nuanced question because clearly the reason that patients tear their ACLs, and why do some patients recurrently tear even our best or well-performed graft surgery, reconstructive surgery, it's hard to, there's so many different reasons why that happens. I would say in the last 5 to 8 years or so, a lot of data has come out about the alignment of the bone. And so let's say somebody has, as an example, too much slope to their tibia. So if you look at the top of the shin bone, it's not perfectly flat. It actually goes down about 10 degrees in almost everybody. That's about average. And that's just how your knee works. But in some patients, they have too much slope. And so it drops more dramatically. That has been correlated with recurrent ACL tear. So there has been some talk of, hey, maybe in these patients, we need to not only fix the ACL, but we need to cut the bone and correct that slope and give them a little less slope in an effort to protect the graft that we're going to put in. The reality of the situation is, academically, that makes a lot of sense. That dramatically alters the surgery. It makes the recovery more challenging. The complication rate can be higher. And trying to tell somebody, hey, we're going to cut your bone for a theoretical improvement in outcome is hard in a first-time surgery. Convince a patient to do that when, in general, the surgery works so well in over 93+% of people. So I think in the revision setting, we look at it a lot. If somebody had just a total gross abnormality, their tibia just did not look like a normal tibia, had too much slope in general, then we would have that conversation with them. But it's not a part of my primary first-time ACL surgery discussion outside of those outliers.
Okay, I'm still that 16-year-old female soccer player. In 8 months, my soccer club is going to Spain. We've already put the money down for it. We have a big tournament. Am I going to be able to play in that? When can I go back to playing soccer?
Yep. So from the very first conversation when you came into my clinic, I've told you that the recovery from this operation is not a time-based recovery. It's a function-based recovery. So some people are ready to go at 7 months and some people are ready to go at 15 months. And I always give them the example of Adrian Peterson, who was a running back for Oklahoma and then in the NFL. He tore his ACL and came back in around 7.5 months or so, and had the second most number of rushing yards in the NFL history that first season back. Talked about he was in preseason games and having scar tissue, feeling like it was breaking up in his knee as he was running down in the first game or two back. But that guy was a statue. His entire job was to get ready, and he came back in 7.5 months or so. And then you look at Derrick Rose, who was the NBA's youngest MVP, and he took 15 months to come back from his ACL. So what's the difference there? They're both elite athletes. At the prime of their career, their only job is to rehab that knee, and one was double the amount of time the other one was. And a lot of that is because not everybody's recovery goes the same way. The quad muscle is the big stabilizing muscle of the knee joint, and that doesn't always recover as fast in a lot of patients as you want it to. And then the psychological readiness plays a big role too. We have found ways to try to improve that. So protein supplementation around the time of the surgery can help improve quadriceps strength. We've got a lot of data in the knee replacement literature and spine surgery literature that shows that, and we've extrapolated that to our young athletes. We're very diligent about our return to sport protocols. So it's not just one test. And I tell a family, just because we've got 8 months as a deadline doesn't mean that has to be the deadline. We will focus on, we want at least 90% strength of one limb compared to the other, as is measured technically by a physical therapist. We have them take a return to sport test, which is a series of exercises that are both focused on time and strength and form to ensure that when their quad fatigues, they can still protect their knee and land appropriately. And we talked about the psychological readiness test. There are ACL specific psychological readiness tests that we make a lot of our patients take. And so it's not just one factor. It's a multifactorial decision that helps us say, okay, now you are ready. And even then, the only way to totally mitigate any risk is to not go back to a cutting and change a direction sport. And that's not why we're doing this operation for him.
Okay, well, I'm 4 months post-op. I can pass all your tests.
Yeah.
Am I going?
Yeah. So probably you're not passing all my tests.
Okay.
Yeah. That's the benefit of having multiple tests. Very few. I mean, I think there was a huge race, and so.
But there's no minimum time that you would just not go past.
I would think if somebody at 6 months is really interested and passes all the tests, we would probably re-MRI them at that stage and say, what does your ACL actually look like? And if it's nice and mature and looks like the ligamentization has occurred and that sort of thing, then maybe we let them back. But there are great data that show that between month 7 and 8 and month 8 and 9, there is an 18% reduction in retear rate each of those 2 months, just by continuing on with the therapy. So if you're 35 or 40 and you're at that spot at 6 months and you're going to go back and do some hiking and that kind of thing, great, I love it. And cutting and changing direction exercises, great. But if you're the 15-year-old football player trying to get back at 6 months, you're asking for a recurrent tear.
I want to ask you about some of the kind of buzzword topics that people, they hear of a professional athlete doing, and therefore it's solid level 1 clinical evidence that this is going to work. Talk to me a little bit about blood flow restriction therapy.
So BFR, or blood flow restriction therapy, is a way to try to get more strength in a limb. And so a tourniquet is put on at the time of your physical therapy exercises, and it's inflated in an effort to try to drive that muscle to oxygen deprivation and improve the way that the muscle responds to that to allow it to grow faster. There are some studies that show improvement in strength, and there are some others that show it doesn't really help as much. It's become very popular. I would say most physical therapists probably utilize it as part of their routine. Kind of falls on the line of electrical stimulation too. It's very useful in some patients, doesn't necessarily work in everybody. So trying to get that quad to fire is our number one task, and that's the big the inhibitor to return to sport is your quad and glute strength and dynamic control of your knee ready. So again, it's not one thing, but that's another arrow in the quiver of a physical therapist or as part of our rehab protocol. And it's safe and effective in a lot of patients, non-invasive in general. And so it's a reasonable thing to consider these.
And the big one, biologics. We'll start with PRP. Is there a role for PRP in ACL reconstruction?
Yeah, I always tell my patients, we're going to have all the free PRP you want floating around that knee, because in order to do your ACL, we're going to drill a tunnel in the femur, and we're going to drill a tunnel in the shin bone. And there's going to be stem cells. There's going to be growth factors from the bone. It's going to bathe the graft in it as it drips over that coming from the tunnel, and you're going to have blood and marrow all across the knee. And so it's the reason why we've known for a long time that if you repair a meniscus, the cushion that sits in between the two bones, in isolation, or you repair a meniscus at the time of an ACL reconstruction, the meniscus heals much better at the time of an ACL, because you have all those growth factors floating around the knee, not because we injected them, but because they were there from the tunnels. So routine administration of PRP and or stem cells at the time of an ACL reconstruction is not a standard of care at this stage. But in isolation, say trying to get the meniscus to heal, if we're not drilling those tunnels, there is definitely a role for either picking the bone and creating little tunnels to try to recreate that environment, or injecting bone marrow aspirate or PRP or both into the knee to try to facilitate that environment.
Okay, let's do another hypothetical. I'm a 48-year-old male. I like to play doubles tennis, occasional singles. I go snow skiing, once a year. Other than that, I'm not a runner. I don't jog. I don't play any other what we would call level 1 sports with a high degree of cutting. I went skiing. I tore my ACL. I have a sprain of my MCL, my medial collateral ligament, and I have a little tear in my lateral meniscus. It's vertical, so straight up and down, and it's in an area that has blood supply. What are you telling me I need to do?
So that's me. So I'm a 47-year-old guy who likes to ski and play tennis and do that sort of thing. I would have my ACL reconstructed. I think in an effort to go back to cutting and changing direction sports and be confident with it, I'm probably doing an allograft ACL, so cadaver tendon ACL reconstruction, and probably trying to put.
You're underselling yourself. You were a collegiate tennis player, and you play. What's your tennis ranking level? I don't know how it works, but
it's a 4.5 right now.
Yeah, so that's, I know, very, very good. You're going to let yourself have an allograft.
Yeah, I would have an allograft, and I would repair that meniscus in all likelihood, because it's got some blood flow to it, in an effort to try to maintain as much cushion between those two bones to reduce my risk of arthritis as I age. I think that the data is fairly strong that in my age group, cadaver graft and using my own tissue has equivalent outcomes from a re-rupture perspective. You don't rob Peter to pay Paul, so I don't have donor site harvest pain, so it's an easier operation to get over. I'm back on my feet a little faster, just pain-wise. Probably a little easier to get my range of motion back because of that lack of donor site harvest disruption. And if it was my first surgery, I'm probably not doing an LET on it, just because I'm not a loosey-goosey guy. I've got pretty stiff joints in general. So I think an ACL reconstruction with cadaver graft and meniscus repair, and then return to sport protocol that focuses on psychological readiness and dynamic control of my knee, and I'm not rushing back. I'm making sure that I'm optimizing all the things I can to reduce the risk of recurrent injury.
Is there a role for bracing?
non-operatively, like before surgery. I think
Or afterwards?
yeah. So before surgery, there are some protocols that say, hey, maybe if we get to this patient within the first 3 or 4 weeks of their injury and we brace them at a very specific angle, 90 degrees of knee flexion, and then slowly get their motion back after that, and then rehab them, that by 4 or 5 months, they can return to sport. And that was an original study that just said, hey, if we brace all these people, what happens to them? And some of those people do very well. Some of those people do very well. Others, however, don't, and they have recurrent instability. That rate is actually pretty dramatically different. They just published just this year, I believe, a study that compared surgery to bracing, and is dramatically different in terms of instability down the road and meniscus injury. More importantly, like 60% or something like that, maybe 50% of the bracing group ended up with meniscus tears compared to 2% of the surgical group, which is, we've talked about already, dramatically alters the long-term outcome once they've had a meniscus injury, with a higher incidence of arthritis and that sort of thing, if you can't repair that meniscus.
All right, get out your crystal ball. In the next 5, let's say 10 years, what do you see as being the next big advancements in the treatment of ACL injuries?
Yeah, in all of orthopedics, I think biologics, meaning using your own body cells to help heal it, will be an important thing. I think the number one biggest issue, or the place that we need to make the most growth, is in the rehab aspect of it. Is how do we ensure that what we think we're doing rehab-wise is appropriate at the right time frame? How much can we stress the graft? How much can we stress the knee? How do we build strength? I think nutrition's going to play a big role. And then in the operation, I do think there's going to be a role for biologics, and that's using your own body cells to try to get it to heal. I mean, we can grow a heart in a petri dish right now, but in order to regrow cartilage or regrow meniscus tissue or regrow a ligament in the middle of a knee, it's in an aqueous environment. It means it's in fluid environment. It's in constant motion, and it's not just a hinge joint. It's hinge with shear and rotation. It's a very challenging environment to get your body to heal something, and that's going to be a big push down the road. Is how do we recreate that structure to the best of our abilities using your own cells and tissue?
So one of the reasons I created this channel is that we just don't get to spend enough time with patients, and there's typically some gaps or holes in their knowledge that we see, and I've addressed that a lot on this channel with joint replacement. But what do you see what are some of those holes in patients who have torn their ACL when they come in to see you that you could educate them on?
Yeah, I think a lot of patients would be surprised that just because they tore their ACL does not mean that their knee is totally trashed. That an isolated ACL tear is a relatively uncommon thing. Very commonly, there are bone bruises associated with it, meniscus tears, other ligaments, that sort of thing, cartilage injuries, the protective coating on the end of the bone. And so it's important to figure out what else is going on when someone has an injury. So we do obtain an MRI routinely. It doesn't have to be done emergently or in an emergency room or things like that. Putting people on crutches, getting their motion back. I think it's important for patients not to ignore an injury. When you get a big swollen knee after a non-contact event, you need to see an orthopedic surgeon for that. There is going to be a role for some physical therapy and prehab and that sort of thing, but getting an accurate diagnosis is really important. It's also important to know that you can walk, you can even run without an ACL. What you need it for is cutting, twisting, pivoting, turning. And the decision to have an operation is based on an intimate conversation with your family and your team and your coaches and your surgeon and your physical therapist about who is the best candidate. And let's say you have an older patient population, say it's a 60-year-old avid runner who tore her ACL skiing, and she says, well, I'm active, I have to have it reconstructed. If you give me a few months, the majority of those patients can actually return to full sport without an ACL reconstruction, because as we age, our knee gets a little stiffer, not a little looser. So making that decision to fix it right away is often rushed and maybe an inappropriate treatment for that patient down the road.
And there's actually negative consequences if you try to do the ACL reconstruction too soon after it.
Yeah, so you really want to make sure you get your range of motion back first. So the number one predictor of range of motion after a surgery is range of motion beforehand. So if you go in stiff to the operation and you've rushed it through, then you have a little slower potential outcome afterwards. So there's definitely a role for prehab, doing some physical therapy to get your range of motion back, get your quad firing again, stationary bike with resistance, things like that, and then proceeding with the ACL reconstruction. I think it's also really important to remind everybody that there is not a single published on topic in all of orthopedics more so than the ACL. Easily, if you started reading right now and you're 20 years old, you could read 24/7 of all the ACL data out there and not finish it before you passed away. That's how much data there is on the ACL. So it's just because your friend had this or your brother had this or that sort of thing doesn't necessarily mean it's the right decision for you. And having that conversation. And so for my patients, I always get to know, what do you want to get back to? What's the sport that you play? What do you have going on in your life? Are you somebody who can devote 90 hours a week to PT? Or are you somebody who's got to go back to their full-time job relatively quickly? And how do we manage that? And so having those conversations are really important in the decision algorithm.
John, thank you.
Oh, thank you for having me. I really appreciate it. Don't forget to like and subscribe.